otologists or surgeons, specialised audiologists, specialised speech pathologists. In Melbourne, we're lucky to have involvement of the engineers who, from the beginning, have been involved in developing the implant, neurophysiologists, teachers of the deaf, paediatricians, radiologists, so paramedical or allied medical specialties, and of course, as you'll see this morning, you need cooperative anaesthetists and nurses. Sometimes they're not all that cooperative. But the otologist has got the ultimate responsibility for patient assessment investigation, for doing the surgical procedure and supervising the post-operative care, and also responsible, and I think the surgeons need to be aware of this, it's your responsibility to make sure that the device is optimally programmed, that it's optimally functioning, and that the outcomes that are achieved are what is expected. Because there's no point you just doing the operation, putting the implant in, and then not paying attention to what the outcomes are. And in some centres around the world, that's what happens, and there isn't adequate follow-up of what the outcomes are. So in terms of assessment and investigation, we want to know, is the patient suitable for a cochlear implant? We want to know what the prognosis for performance with an implant is, and that depends on assessing the etiology of the hearing loss pain. So that's an otologic diagnostic issue that then relates to whether they can have an implant and how they'll go with an implant. And then, of course, the surgeon is responsible for the consent. In other words, the patient understanding the potential benefit, the potential risks, and the potential lack of benefit. So I'll just run through some well-known examples. From the etiology point of view, typically hearing loss is congenital or acquired. It can be familial or non-familial if it's congenital, and if it's acquired, then it can either be prelingual or postlingual.